Can everybody hear me okay? Okay. What's my name again? Oh, well, I'm actually wanted in about 48 states, so it's pretty easy to find my name. Dr. David Hutchings. I was supposed to go on around 4 o'clock, I think. So we kind of switched some things around. So I'm the guy at the bottom there. So, yep. And you're in trouble, by the way, because you're sitting on the front row. Yes, yes. So, yeah, you stay in trouble. So do I. And with that being said, can I get a honest response from everybody, from the men in the room who are currently, who has ever been in the doghouse with your wife? I don't see many hands. Come on, y'all, be honest, seriously. All right, I see a few more coming up. So I was really excited to be able to come to Florida and present because I'm currently in the doghouse with my wife, and let me tell you exactly what happened. I come home from Virginia late Friday night and was really looking forward to sitting down and relaxing, watching a little sports. And if you can kind of picture it in your mind, I'm sitting there, got my recliner, I kick my feet up, and get me a cold drink, throw on some sports, and it was only just moments later I hear a beep. And I was like, what is that noise? So I thought, okay, I'm going to ignore it. That's what men do the best. We just try to ignore things. So about 5 minutes later, beep. I was thinking, really, this is going to drive me nuts. So my initial inclination was it was my fire alarms needed batteries. As I started to dig a little deeper, it was the home alarm system that was actually starting to beep. So I thought, okay, it's 10 o'clock at night. I went upstairs to the pantry to put in some batteries. Well, I don't have any batteries. So then I got to get up and go to the gas station where I paid about $150 for 2 batteries. I mean, they really charge you big time because they know you need them, right? So my whole goal, again, is just to get a little bit of R&R. And so I insert the batteries, sit back down, kick my feet up, beep. I was like, unbelievable. So I had to call ADT, the alarm system folks, get on the phone, got a really nice lady on the phone. And she said, well, this will be a very easy fix. I said, ma'am, for my sanity tonight, I just need the thing to stop beeping before I just rip it off the wall completely. Well, this is a very, very easy fix. All we need is your security code. I said, okay, good. Can you pull that up for me? Because I don't know what it is. Well, no, sir, we can't. We're unauthorized to do that. I said, oh, okay. So I run upstairs. My wife's reading a book. My wife is also a pediatric speech pathologist. She specializes in autism. And I said, sweetheart, and I still got the lady from ADT on the phone. And I say, can I get the security code? Because the thing keeps beeping, and I'm just going to end up going postal before it's over with tonight. And she said, oh, yeah, sweetheart, it's easy. It's our anniversary. And so I thought to myself, no matter what, I'm in trouble. The ADT lady, I mean, she's in tears laughing, right? She's just cracking up. And I said, ma'am, in a real quiet voice, I said, is there any way that you can pull this string for me and figure out what the security code alarm is? No, sir. And again, she's like crying, laughing. I had to go back into my bedroom and ask my wife, can I have our anniversary date? So if any of you have open rooms that I can actually spend the night with you for the next week, I'd be much appreciated about that because hopefully she'll get over that. But now I do have it remembered, so even thinking about tattooing it on my arm at some point. So anyway, how many of you, give me a show of hands, how many people know what a speech pathologist does? Okay, a few. There's a misconception out there that we teach people to talk. And actually, if we look at the totem pole of what a speech pathologist does, that is actually last on the list. And when it relates to, obviously, the conference today in Parkinson's, there's going to be 3 major areas I really want to focus on today. Number 1 being swallowing disorders. And when we define a swallowing disorder, we define it, the medical diagnosis for that is dysphasia. So what I really want to do today is give you enough information where you're going to be able to recognize some symptoms of dysphagia. The swallowing problem in the elderly group in general is one of the reasons that we see such a high prevalence of pneumonia. So we're going to talk about some of the different symptoms. We also are going to be talking about cognition and define for you what cognition and what the speech pathologist is going to do for that as well. And lastly, we're going to talk about voice disorders. It was mentioned earlier. I love the description that we talked about earlier, but we're going to go a little bit further in depth into some of the vocal characteristics that we see in Parkinson's, and also what can we do about it. So that's kind of how we're going to look at it right now. With Parkinson's aside, the baby boomer population right now is on us, and the research is calling this the Silver Tsunami. All right, so every day we have 7,918 people turning 65. Every day, 330 per hour. So if we take the Parkinson's piece out of it, the things such as swallowing problems and voice disorders and cognitive issues, we're just going to see these continuing to go up and up. And I'm going to show you some prevalence of some swallowing disorders here and some of the statistics on it to really kind of drive it home to you of how prevalent it really is at this point. But if we look at just the areas of speech pathology in which we treat, this is kind of the hierarchy of it. Swallowing disorders obviously is number one. That puts, if we don't catch this, it's not really a matter of if a patient is going to develop pneumonia, it's just a matter of when. So we're going to show you some symptoms, and that's where I think that there's a percentage I'll show you here in a couple minutes that in the past decade, so over the past 10 years, we've seen the hospitalization rates for swallowing disorders go up by 94%. So that's telling us, what does that tell us? It tells us that we're not catching it. We don't know, we're not looking at the symptoms. So it's very powerful that you all know the symptoms of this. We will be talking a little bit about cognition and also voice disorders, but this is kind of the hierarchy in which a speech pathologist does treat. So if we look at, as what the conversations are today regarding Parkinson's, if we look at swallowing disorders, 80% of patients with Parkinson's will have swallowing problems. 80%. If we look at the voice disorder piece of it, 89% of Parkinson's patients develop voice disorders. I think it was a great description earlier of some of the vocal characteristics to be looking for. But here's the alarming piece, is that if we have 89% of the people with Parkinson's who develop swallowing or develop voice disorders, guess how many people actually seek treatment? 3 to 4%. 3 to 4%. And it all ties together. And I'm going to bring, so I don't want you to think about all these different areas of different entities of treatment. Voice disorders can actually impact the swallowing. Cognitive and memory problems can also impact swallowing. So we're going to talk about those as they relate to Parkinson's and how they're all kind of intertwined. Okay, so let's dive into swallowing disorders or dysphagia. I put this into my presentation because this is me at home. This is me at home. My wife has 2 cats, and whoever coined the term cat nap, you know, they actually sleep 17 hours in a day. So that's quite a big nap that they take. But I think this is going to end up being me one day to wake up and the cats can actually be wearing my dentures. So I thought that was a pretty good interlude into the swallowing portion of things. But so let's define what dysphagia is and what a swallowing problem is. When we look at a swallowing problem, it can happen either with the mouth, with the throat, or with the esophagus. So when the speech pathologist is going out to look at that swallow, they're looking at the mouth, the throat, and the esophagus. So when we diagnose it, and these are some terms that you may run into at some point, if a patient has an oral dysphagia, that means that they have a swallowing problem at the mouth stage. If they have one where it's a pharyngeal or throat, then they have a problem with the throat stage of the swallow or the esophageal. So basically what we do, it's defined by a swallowing problem anywhere from the mouth all the way down to the stomach, and we diagnose it based on this stage. So I thought about this lecture quite a bit, and I thought, what would be the best way for me to get across to everybody on how to recognize symptoms of swallowing problems, but also what a disordered swallow looks like. So we have to kind of understand what normal swallowing looks like before we understand disordered, right? Everybody agree? Okay, when we look at the normal swallow in the prevalence of swallowing disorders, the hospitalization rates, again, at about 94% over the past 10 years. So that's a huge, huge jump. And then we look at Looking at the prevalence in terms of the geriatric population, about 44%. That's an older statistic. This has actually gone up to about 49%. So we do just see it in normal aging. Dysphasia, swallowing problems are mostly associated with advanced aging. When we look at the patients within our organization with emeticys, our typical patient does not have one diagnosis. They don't have one medication. So how each diagnosis impacts the swallow really varies, and we'll talk about that here in a couple minutes. But what we have, going back to that high hospitalization rate, what we have is this snowball effect. So many people are so concerned with aspiration. And how many people know what aspiration is? All right, for those of you that don't know, I grew up in Mississippi, and we would call it when you swallow down the wrong pipe, run the wrong tube, and you cough and you sputter and those types of things. That is aspiration. The problem is that so many people get wrapped up into aspiration that they don't think about the other symptoms of dysphagia. So we're going to talk quite a bit about that. But as we have a patient with a swallowing problem and it's not noticed and it's not picked up on, we have this snowball effect. We have patients that go through weight loss. We have poor nutrition. We have dehydration, the social isolation, and also the aspiration pneumonia that's a part of that. So when it's not noticed, obviously we are seeing this snowball type effect. And that would definitely explain why we see such a high prevalence of the hospitalization rates go up. So let's talk about what the normal swallow looks like. Normal swallowing, every single day, every person in this room is going to swallow about 600 times a day. And you typically never think about it, right? How many people in here actually think about every time they swallow 600 times a day? Do you actually sitting there consciously thinking about swallowing? No. So it is a very primitive function, but basically when we're looking at this, we can kind of draw a circle around the mouth, and as the food goes into the mouth, it's chewed, or whether it's a liquid, it's prepared. And once the point that it gets to this portion right here in the back of the throat, then your throat stage or your pharyngeal stage kicks in. It's a very quick reflex. The Adam's apple moves up, it moves down, and then it throws the food down into the esophagus. So we're basically looking at based on the stage. So it's a very quick and it's a very, very coordinated motion. So what we have here is a patient that I have that is considered to be a normal swallow. You can kind of think about those circles, around the mouth and around the throat and around the esophagus, and I'll show you on this side too so you can see it. So we have just the mouth, the food goes through the mouth, it goes down through the Adam's apple moves up, and it shoots it right down to the esophagus. So that's a very, very, what we call a normal swallow. If we're looking at the stages, it's very quick. 1 second, 1 second, 1 second for the swallow. So it's a very, very quick coordinated motion. And then also to look at another normal, you can see again that even if you've never seen one of these types of x-rays, you can see that this is a very quick and very coordinated motion. That dark area within that the food is going down, you can clearly see there's no food left over, there's no coughing, but this is what we would be considered to be a normal type swallow. Now, looking at symptoms, these are the things that if you take nothing out of what I say today, this is the most important information that I think you really need to remember. First of all, when somebody does aspirate, when somebody has a problem swallowing and the food or the liquid gets in your lungs, Earl, what happens? You're in trouble. Yes. Right. I'm not picking on you anymore. Marilyn, what happens? You choke. Right. You cough. What else happens? You can't breathe. Good. Do your eyes water? Your nose runs? Yeah, exactly. So we need to be thinking that 60% of the time, this is a huge percentage, 60% of the time when somebody does aspirate, when things get into the lungs, guess what? No, they don't die, but I was actually going to a nicer road than this, but I'm not picking on that table either anymore. Where was I? What was I talking about? Oh yeah, I remember. So 60% of the time when somebody does aspirate, they do not cough. Okay, so it's more of an asymptomatic. So you may have, when we swallow down the wrong tube, I actually did it this morning, and I cough, my eyes water, my nose runs, you take the cough out of it, and all of a sudden you have a runny nose and watery eyes. I can't tell you how many times I've gone to see patients and they have chronic runny nose, chronic runny eyes, and all of a sudden they're on all these allergy medications and all these things, but you start to dig a little deeper and they've got a weight loss, and they've had these pneumonias, and you've got to be thinking, well, maybe this isn't allergy related. So that's one thing to be looking for is the watery eyes, the runny nose. There's a lot of different symptoms of aspiration. And unfortunately, if we're looking for a patient to cough to identify whether they have a swallowing problem, we are going to miss it 60% of the time. So some of the other symptoms that you have, frequent temperature increases, just the lack of eating, maybe holding food in the mouth, losing food out of the mouth. Weight loss is definitely one of the big ones we want to look for. Chronic hiccups, those types of things. And what I mean by a wet, gurgly vocal quality is patients many times will just sound like they're talking underwater. They have this very gurgly type vocal quality. And simply what that means is that there's food or liquid that are sitting right there in the Adam's apple, and when they go to talk, it just basically sounds like they're very gurgly when they speak. I think that a lot of these symptoms, I don't want to read over all of them for time's sake, but I know that you have the presentations and you'll be able to kind of go back through these and look at some of these. So again, aspiration just simply means that something has got into the lungs. And we just have to remember that patients are always not going to cough. The cough is simply just a reflex. So, looking beyond that. So if we are seeing symptoms of runny nose, watery eyes, loss of weight, maybe a spike in temperature, recent pneumonias, those types of things are very, very important to look for. Dehydration, those are the things that we need to focus on. So many people, when we look at swallowing problems, they are so wrapped up into aspiration. But there are so many other things that we need to be looking for besides just the aspiration component. Okay? Any questions? Good deal. Everybody's still awake. This is great. All right, good. Okay. So these are the main ones I would look for. Obviously, coughing when you're eating. Now, I do want to clarify, if you have a runny nose and you haven't had anything to eat, then more than likely that runny nose has nothing to do with the swallow itself. But if you are seeing some of these symptoms as they correlate with eating, then obviously this is something we want to pay a very close attention to. I'm a firm believer that if we think this might be an issue with you, it's better to take the conservative route and have one of these x-rays and go ahead and say, okay, well, this is not the problem. We can mark that off the list. So now that we know what normal looks like, this is a patient that I had with more of a, what I would consider more to be profound type swallowing issue. So can you agree that this looks completely different than the first one you looked at, right? So, and I'll show you on both sides, but you can see that the food is basically all in the throat, and this is aspiration. Okay, and I'll show you one more time so you can get a good look here. See it? So what happens when the patient coughs? Nothing's coming out, right? Nothing's coming out. So over here, for the folks who couldn't see it earlier, that portion, everything black that goes down, is going right into the lungs. So obviously this pushes patients at a significant risk for developing an aspiration pneumonia. So when you can actually see the x-ray of what a normal looks like versus an abnormal, it really starts to put a truer picture of what aspiration looks like and also what kind of risk this patient is at. So it definitely helps, comparing the normal to the abnormal to see the significant differences. Yes?
What happens to the food that goes into the lungs? Does the body break it down occasionally?
It depends. There are lots of research that looks at, and let me just kind of throw this out there, one of the hardest things for one to drink is water. And I know that may be a little bit surprising, but water moves through the throat very, very quickly. So your reflex in your throat, your Adam's apple, has to respond very fast. So the research that looks at that indicates that water is a neutral pH, so if it is entered into the lungs, then the research is showing us that it actually can be absorbed into the lung tissue and it'd be okay if we have good oral care, okay? What happens to the other food that enters into the lungs, it does grow bacteria, and that's what creates the infection, and then the pneumonia sets in. Okay, so does that answer your question? No. Obviously, it would come out. Obviously, we'd be on antibiotics and those types of things to fight the pneumonia itself. So it's not going to stay there forever. No, it will break down after all. But such things like food and those types of things, when they do enter into the lungs, they're much more susceptible to developing aspiration pneumonia from that. So it is very important that if you've had a pneumonia in your history, this is something to be thinking about. And obviously, as a percentage, I said earlier that we're looking at 80%, which is an extremely high percentage of Parkinson's patients do have swallowing problems. So it's something to definitely be looking at. Yes, sir.
What procedure for a pill that gets stuck in your throat?
That's a good question. So for those who didn't hear, what would be the procedure for pills that get stuck in your throat? There are different types of swallowing problems. There's different types of dysphagia. What we call pill dysphagia is one of those. So what we want to do is actually identify what stage of the swallowing problem is the problem with that, and we're going to try to strengthen it. The good news is that this patient here that I had, and no matter the type of diagnosis that we're looking at that's causing the swallowing problem, it is treatable, absolutely treatable. And again, it's better to be proactive to recognize some of the symptoms that we're looking at. But the treatment regimen is very complex. Even with a pill dysphagia, one that may be onset from Parkinson's or a stroke or whatever the onset may come from. Did that answer your question? Okay. You had your hand up. I thought you were going to throw something at me at first. So I'm glad you didn't throw anything at me. All right, so different diagnosis. Yes, stroke is one of the ones that we're very concerned about. About 74% of patients with stroke will have swallowing problems. Every single type of dementia, doesn't matter what type it is, as it progresses, we will have swallowing problems from that as well. Your progressive neurological diseases. Patients with, I don't know, I heard you talking about earlier about COPD and some of those things. Anything that impacts the patient's respiratory system, whether it's emphysema, chronic bronchitis, the COPDs, anything that impacts respiratory will impact swallowing. And the reason that is because swallowing is the only thing that you do in the human body in which you stop breathing. And so there's a very delicate coordination there. So with this one thing that we do see a lot of swallowing problems that onset from diabetes, renal insufficiencies, and a lot of different types of conditions. Real quickly before we get into the voice disorders and some of the cognition piece is I get a lot of questions, whether it's with patients that I see or we had one last week with a dementia they were wanting to put in a feeding tube. And unfortunately, the feeding tube topic just keeps coming in. When we talk about feeding tubes, we go into this turmoil because we have a lot of people that don't want them, and then they want them, then they have cultural things against it, and so there's a lot of things that go here. When I thought about doing this presentation, I just want to be able to tell you what the research says on feeding tubes, and it's not very productive. First of all, let's take Marilyn here. Let's say that you are eating by mouth, okay? And then we're going to take Joanne. You mind if I pick on you? Okay. And Joanne is actually on a feeding tube. Okay, so we have a patient over here who is on a feeding tube, and then we have another patient here that is not. The prevalence for a patient, these two patients, to develop aspiration pneumonia are the exact same. So even if you have a feeding tube, it does not mean that you're going to be out of the window of developing this type of pneumonia. A couple of other things too is feeding tubes, as the most recent literature, have never been shown to increasing weight or nutritional status. Obviously it brings in some other things such as weight loss and those types of things. I had a patient last week with a feeding tube. He's lost 80 pounds in 1 year. So the question is, how's that working for us? So, but that is what the research says. I think everybody has their own thoughts on it. But that's what the current research is indicating for feeding tubes. And this is not just for the Parkinson's population. This is for across the board in terms of feeding tubes. Okay, any questions on swallowing disorders? Yes? Right, the diverticulitis in the esophagus. Yeah, and that's diverticulitis or diverticulums. Obviously, diverticulitis would be the infection portion of that. Really, there are a lot of things that we can do with that stage of the swallow as well. There's a lot of compensatory things that we can do with changing your diet around and doing things that actually going to make it a little bit easier for you to manage with that condition. So the treatment for the swallowing problem doesn't stop at the mouth or the the Adam's apple. We do have a pretty good treatment regimen to also focus on the esophageal portion of it, whether it's a diverticulum, whether it's a stricture, reflux, those types of things. So that's the case, and obviously if it's impacting the esophagus, it also can be impacting the throat as well. So, and I'd be happy to talk to you more on things that may be things that you can do at home, but also in terms of questions for your physician as well. But any other questions? Yes, ma'am. I'm getting my exercise today. I'm sorry, I couldn't hear.
X-ray to diagnose a swallowing problem.
So the question is it necessary to do the actual X-ray to diagnose it? And the answer to that is no. In home health care or whatever the setting may be, the speech pathologist is going to go in, they're going to do what we call a bedside swallowing assessment to figure out exactly what we're looking at. I only recommend the videos when I have a question that simply just cannot be answered. If a patient is silent aspirating, if they're in that 60%, we're not showing a lot of symptoms, then I probably will show a video swallow and get an X-ray on that. So the question of that is that no, we don't have to have the X-ray to diagnose it. We can actually do it right there within the home. Okay, so definitely it gives us, I think doing the bedside actually gives us a little bit better information than just an X-ray, because those X-rays are what? A few seconds in length, right? We don't really get a full picture of that swallow with only that X-ray. Yes, sir?
That was my question. Is that just a regular X-ray, that picture?
Yes, it is. It's what we call a swallow X-ray. So, but not all patients that I treat for swallowing problems, I recommend the X-ray. Just when I can't quite put my finger that something else is going on, that's when I'll say, okay, let's do the X-ray. Yes, sir?
Is there any relationship between tonsillitis between individuals who have had tonsils and adenoid surgery?
No, not at all. Now, if they're inflamed and those types of things, it can impact the movement in the throat. But if they've been removed or not, there's no differences with that. Yes, sir? Well, with the pneumonia with swallowing disorders, we do develop what we call an aspiration pneumonia. There are different types of pneumonias, obviously. And obviously the pneumonia, the main treatment regimen is obviously keeping the patient hydrated, also with antibiotics and those types of things. One of the things I think is one of the things I try to get across every time I do lectures is that, you know, we go in and we have a patient with pneumonia, we put them on an antibiotic, but does anybody ever sit there and say, why did we develop pneumonia in the first place? So identifying the root cause is very key. But yeah, treatment of the pneumonia is definitely very, very important. It can be treated, but my main stress is that we want to find the root cause of that. Because if it is swallowing related, then the pneumonias will keep reoccurring. Okay? Okay, cognition. How much time do I have left, Lisa? 10 more minutes. Okay, cool. I'm going to go through cognition fairly quickly, then I want to show you a video on the voice disorders, something that we do want to talk about a little bit more. The speech pathologist is going to be looking at cognition in many different areas. We have many areas of memory besides just short-term memory. So if I'm going to say, hi, I'm David. Yeah, okay. How do you remember my name? I know I'm dashingly good looking. Right, yeah, and I'm tall. Yeah. So do you repeat my name several times? David and Goliath. How do you remember that? Okay, good. So we have tied it to a previous memory. So what our SLPs are going to be doing is as we repeat a name, so we have new information coming in, right? That immediate memory lasts for about 10 seconds. There's no way for us to remember my name unless it's repeated or tied to another memory. At that point, so things have to be repeated over and over and over. As we do that, then it moves over into the short-term memory area, where it lasts up to about 20 minutes or so. Then it goes into the long-term and then the remote. Remote memory is something that I can remember my first pet's name or the address that I lived on when I was growing up. These are things that are remote memory. The ability to remember your spouse's name, or maybe remember your anniversary. Right. So that's where I'm having a problem with, is the actual remote memory piece. I'm working on that though. And then we have semantic memory. That simply just means memory from fact. So what's 3 times 3? 9. Good. I didn't see anybody pull out iPhones or calculators there. So we just know that, right? When it comes to episodic memory, I'll give you an example on this, is that I drove from the airport, Tampa, over here yesterday. I only took 4 wrong turns, which is pretty good for a guy. But I know how to get back there tomorrow because I've done that, okay? Yeah, I actually was going towards Orlando. No, I didn't ask directions either, right? Another typical guy. Forget the anniversary, you don't ask for directions. Yes. So there are many different types of memory, but the memory really builds upon itself. When it comes to higher level executive function, these are things like problem solving. We do these things all the time. If we lock our keys in the car, right, we're trying to think about what's the best way to get my car going, what's the best way to get my keys out. So you have a bunch of different solutions and you're trying to figure out what's the best solution for this. Probably not breaking the window would be the best solution. So you might call AAA or whatever. So you're having to deal with one problem and offer up several different solutions. And then we have the ability to communicate. I, right now, have a bunch of ideas in my head that I'm trying to communicate to you. So that's expressive language. And then we have patients who, obviously I hope everybody in the audience is listening to me, that would be receptive. We have patients, obviously with many different medical conditions, where they have either troubles expressing what they want to say or actually understanding speech. So that's something else that we're looking at. So really in a hodgepodge, that's what we're looking at in terms of cognition. However, if a patient has a cognitive problem, it does impact swallowing. Remember I said all this stuff is mixed together, right? So this is a picture of a patient who has a cognitive issue, some cognitive impairments, and they basically chew food and they never advance to the throat stage. So you can see as the longer the person chews, the food just gradually is pulled down into the throat itself. So again, these things are tied together. We have swallowing, a very primitive type function that we don't think about it. We do it 600 times a day. But if there is cognitive impairments, whether it's with problem solving and those types of things, then we also will see it impact swallowing as well. Okay, voice disorders. I only have a few minutes left here, so I do want to get through the voice disorders portion. I think these first 2 statistics are just astounding. When we define a voice disorder, we look at it basically from the respiratory system and also from the throat. Okay? If a patient doesn't have the adequate respiratory support, they're going to have a problem with voicing and projecting their voice. A lot of times these patients will sound very, very breathy. And at their hardest and most projected voice, it will sound very breathy. So they cannot communicate even from room to room. Some of the voice characteristics that we have are weak voice, the low voice volume, very monotone. But again, just overall, they cannot project that voice to get to even communicate from one room over. Is this treatable? Absolutely. Absolutely. How many people have heard of Lee Silverman voice treatment? Quite a few. This is something that we have put into our speech pathology program with great success. We have 600 speech pathologists in this country that work for Emeticis, and about 121 right now are trained in Lee Silverman voice treatment. Very specialized treatment program to work with the voice box and also work with the respiratory system itself. So I have 2 videos I want to show you. One of a patient that went pre and post Lee Silverman voice treatment. And then the next video I want to show you that won't take very long is a patient that went through LSVT big that works with the balance working with physical therapy, and also working with some of the daily functional things that you do in your home every day, whether it's bathing, brushing your teeth, these types of things. And so we have those two different types of Lee Silverman voice treatment. So this is the first video that I want to show of 2 videos. And then I have a couple wrap-up comments, and we're going to get y'all, now that we've talked about swallowing, it's going to be time for lunch, right? So that's good. All right. So this is Shirley pre and post Lee Silverman treatment.
Have you noticed any changes in your speech or your voice that you would associate with Parkinson?
Y'all pull up the volume.
Yes, I don't speak loud enough a lot of times.
Anything else?
Hoarse.
Anything else?
I stutter, which I never did before.
Do this for me if you would. Take a deep breath and say ah for as long as you can. Good for you. Okay. Would you say Parkinson's disease has caused you to talk less?
Yes.
Because?
Because I stutter and then I can't be heard. If there's noise in the house, like when the kids come over, nobody pays attention to it because they can't hear me. Until I get mad and then yell.
Take a deep breath and say ah for as long as you can.
Yeah, quite a bit different than what we heard a second ago.
Have you noticed changes in your speech or your voice as a result of the speech therapy?
Oh, yes.
What have you noticed?
I talk louder. I think louder. I'm going to sing with the Sons of the Pioneers one of these days with my voice.
Good for you. That's excellent. What practicing do you do at home?
My ahs, my highs, and my lows. And I read out the mail out loud.
Excellent. Do you feel like practicing helps?
Oh, yes.
Okay. Do you feel as though people can understand you all of the time now?
Majority of the time, unless it's my husband, and he'll say, "What? I can't hear y'all."
Good for you.
But I think he does that just to be cute.
I think he does too.
That'd be the boat that I'm in right now. So.
Has anyone commented that it's easier to understand you now?
Oh, yes. I set some of our friends back when we went to their house, and I talked loud. Lou says, "What the hell happened to you?" My daughter said, "Oh, Ma, that's you?"
Isn't that good? Don't you feel wonderful?
Oh, yeah, because now she can't say, "I didn't understand what you said."
Right? No excuses, right?
Yeah,
That's
no
right.
excuses.
All right. So what do you do when you want to be as easy to understand as possible?
Think loud.
So, and this is going to be somebody walking who has gone through the LSVT-BIG program, working with balance and occupational therapy. So on the right side, you're going to see pre-treatment. On the right, you're going to see after. There's an astronomical change in his mobility and his walking.
And that's
LSVT loud. That's working with the physical therapy and the occupational therapy for mobility. LSVT big, yes. Sir? Same guy on each part. You notice no cane. You notice bigger steps. There's more rhythm to the gait. The posture looks better. So quite a bit of difference. For time purposes, I want to go through 2 more slides here because I know everybody's getting hungry and we're right before lunch. So the last thing I want to talk about is that as our goal all the time is to keep natural communication as long as we want to. All right, that's as long as we want to do. We want to be able to speak by mouth and communicate by mouth. What we've done now in home care is that we've decided to put in a very specialized approach called Augmentative Communication devices. This is a fancy terminology for using a computer to talk. So even as the voice begins to decline and we're unable to use our voice, a speech pathologist can come into the home, do a very specialized treatment approach to figure out what type of device the patient needs. It's not a one-size-fits-all. These are extremely tailored to that patient. So you can put medications into these things. Obviously, it communicates for you. It opens up your own garage door. I mean, you can do everything you want to with these types of devices, but it does speak for you. A very heartwarming story that I had, and I love patient success stories. I had a patient's wife that called me, and she was in tears. And her husband had had a stroke 10 years ago. And so when it came to reestablishing natural communication, we were out of that window. We really couldn't do much to do with that. So what I recommended to the therapist is that what I want you to do is go in and do an evaluation for a communication device. We put the device in place. He started to use it very often. The wife, this is only 2 months ago, the wife calls me and she's in tears. And my first thought is, oh God, we did something wrong. The reason that she was crying is because the first time in 10 years that her husband had told her that he loved her, and he did it via the communication device. So even when we were out of options and think we can't communicate anymore by mouth, that is the greatest story of all time. That is why we do what we do. So the whole point of today was to be able to really outline for you from a Parkinson standpoint of swallowing, understanding the symptoms, looking for those types of symptoms, obviously looking at the cognitive and memory portions. There's things we can do to help with that, and also the voice disorder piece of it. With becoming the largest speech pathology program in the United States of America, we have tried to put in the best clinical approaches ever. So our speech pathologists actually have to go through a 2-day geriatric swallowing course that I teach them. 2 days to talk about swallowing. And then we go through extensive dementia training, Lee Silverman voice treatment, obviously the communication devices, and we don't have enough time to talk about this, but using electrical stimulation to treat the swallow as well. So there's a lot of great assets and features to the program. The main thing here is that whether it's swallowing, whether it's communication, whether it's voice, it can be treated. And we may not be able to get 100% back, but I think it adds such a quality of life for someone to be able to eat what they want to and be able to communicate their wants and their needs. Lastly, we have a press release that came out last week on the clinical outcomes for speech pathology within our organization. And what you see is that the treatment goals that we met for 2011 is a little bit over 70%, almost 71%, compared to the industry in home care is at 51.78%. So when I say that we have the largest speech pathology program in the country, that don't mean anything to me. What it means the most to me is the data that shows that our patients are getting better. And that's the main thing that I'm concerned with. You know, I hope you now have an understanding of at least what swallowing disorders look like, the symptoms, things we could do for cognition, and also for the voice disorder piece of it. Any questions? Yes, ma'am.
Well, it's not a question, it's more FYI. I had a stroke in 95, and I had to do exactly what they said. I couldn't talk, couldn't speak, or anything. And I had to go through the whole routine, not bad, but it takes you over a year to get this back. I couldn't speak at all. Couldn't talk.
Wow.
Couldn't cook, couldn't write.
That is awesome. That is awesome. Wow. See, this stuff works.
Okay, can we hold the questions till the panel discussion? Because it's time to break. You
Running
finished?
out of time. Okay.
It's time to break for lunch, and I'm very impressed.
Thank you, everybody. Thank you very much.